Chronic bronchitis is a diffuse progressive inflammatory process in the bronchi, leading to morphological restructuring of the bronchial wall and parabronchial tissue. Exacerbations of chronic bronchitis occur several times a year and are accompanied by increased cough, purulent sputum, dyspnea, bronchial obstruction, and subfebrile temperature. Examination for chronic bronchitis includes chest X-ray, bronchoscopy, microscopic and bacteriological analysis of sputum, FVD, respiratory function test, etc. The treatment of chronic bronchitis combines drug therapy, antibiotics, mucolytics, bronchodilators, immunomodulators, sanitation bronchoscopies, oxygen therapy, physiotherapy, inhalations, massage, breathing exercises, drug electrophoresis, etc. General information. The incidence of chronic bronchitis among the adult population is 3 to 10%. Chronic bronchitis develops 2 to 3 times more often in men aged 40. In modern pulmonology, chronic bronchitis is defined as exacerbations of the disease lasting at least 3 months over 2 years, accompanied by productive cough with sputum production. With long-term chronic bronchitis, the likelihood of such diseases as COPD, chronic obstructive pulmonary disease, pneumosclerosis, pulmonary emphysema, pulmonary heart disease, bronchial asthma, bronchiectasis, and lung cancer increases significantly. Inflammatory damage to the bronchi is diffuse in nature and over time leads to structural changes in the bronchial wall with the development of parabronchitis around it. Causes. Among the causes of chronic bronchitis, the leading role belongs to long-term inhalation of pollutants, various chemical impurities contained in the air, tobacco smoke, dust, exhaust gases, toxic vapors, etc. Toxic agents have an irritating effect on the mucous membrane, causing restructuring of the bronchial secretory apparatus, hypersecretion of mucus. Inflammatory and sclerotic changes in the bronchial wall. Quite often, untimely or incompletely cured acute bronchitis transforms into chronic bronchitis. Exacerbation of chronic bronchitis, as a rule, occurs with the addition of a secondary infectious component, viral, bacterial, fungal, parasitic. People suffering from chronic inflammation of the upper respiratory tract are predisposed to the development of chronic bronchitis, tracheitis, pharyngitis, laryngitis, tonsillitis, sinusitis, rhinitis. Non-infectious factors that cause exacerbation of chronic bronchitis may include arrhythmia, chronic heart failure, pulmonary embolism, PE, gastroesophageal reflux disease, A1 antitrypsin deficiency, etc. Pathogenesis. The mechanism of chronic bronchitis development is based on damage to various parts of the local bronchopulmonary defense system, mucociliary clearance, local cellular and humoral immunity. Bronchial drainage function is impaired. A1 antitrypsin activity decreases production of interferon, lysozyme, IgA. Pulmonary surfactant decreases phagocytic activity of alveolar macrophages and neutrophils is inhibited. This leads to the development of a classic pathological triad: hypercrinia, hyperfunction of the bronchial glands with the formation of a large amount of mucus; dyscrinia, increased viscosity of sputum due to changes in its rheological and physiochemical properties; mucostasis, stagnation of thick viscous sputum in the bronchi. These disorders contribute to the colonization of the bronchial mucosa by infectious agents and further damage to the bronchial wall. The endoscopic picture of chronic bronchitis in the acute phase is characterized by hyperemia of the bronchial mucosa, the presence of mucopurulent or purulent secretion in the lumen of the bronchial tree; in the later stages, atrophy of the mucous membrane, sclerotic changes in the deep layers of the bronchial wall. Against the background of inflammatory edema and infiltration, hypotonic dyskinesia of large and collapse of small bronchi, hyperplastic changes in the bronchial wall. Bronchial obstruction easily joins in, which maintains respiratory hypoxia and contributes to the growth of respiratory failure in chronic bronchitis. Classification. Clinical and functional classification of chronic bronchitis identifies the following forms of the disease. 1.by The nature of changes: catarrhal, simple, purulent, hemorrhagic. Fibrinous, atrophic. 2.by The level of damage: proximal, with predominant inflammation of large bronchi, and distal, with predominant inflammation of small bronchi. 3.by The presence of a bronchospastic component, non-obstructive and obstructive bronchitis. 4.by Clinical course: chronic bronchitis of latent course with frequent exacerbations with rare exacerbations continuously recurring. 5.by The phase of the process: remission and exacerbation. 6.by The presence of complications: chronic bronchitis complicated by pulmonary emphysema, hemoptysis, respiratory failure of varying degrees. Chronic pulmonary heart disease, compensated or decompensated. Symptoms of chronic bronchitis. Chronic non-obstructive bronchitis is characterized by a cough with the release of mucopurulent sputum. The amount of coughed-up bronchial secretions outside of an exacerbation reaches 100 to 150 milliliters per day. During an exacerbation of chronic bronchitis, the cough intensifies, the sputum becomes purulent, its amount increases, subfebrile temperature, sweating, weakness are added. With the development of bronchial obstruction, expiratory dyspnea, swelling of the veins of the neck on exhalation, wheezing, and a whooping cough like unproductive cough are added to the main clinical manifestations. Long-term chronic bronchitis leads to thickening of the terminal phalanges and fingernails, drumsticks and watch glasses. The severity of respiratory failure in chronic bronchitis can vary from minor dyspnea to severe ventilation disorders requiring intensive care and artificial ventilation. Against the background of exacerbation of chronic bronchitis, decompensation of concomitant diseases may be observed: coronary heart disease, diabetes mellitus, cerebrovascular insufficiency, etc. The severity of exacerbation of chronic bronchitis is determined by the severity of the obstructive component, respiratory failure, and decompensation of concomitant pathology. In catarrhal uncomplicated chronic bronchitis, exacerbations occur up to 4 times a year. Bronchial obstruction is not pronounced. FEV1, forced expiratory volume, greater than 50% of normal. More frequent exacerbations occur with obstructive chronic bronchitis. They are manifested by an increase in the amount of sputum and a change in its nature. Significant disturbances in bronchial patency, FEV1, forced expiratory volume, less than 50% of the norm, and an exacerbation of concomitant diseases. Chronic purulent bronchitis occurs with constant secretion of sputum, a decrease in FEV1, forced expiratory volume, less than 50% of the norm. Decompensation of concomitant pathology and the development of respiratory failure. Diagnostics. In the diagnostics of chronic bronchitis, it is essential to clarify the anamnesis of the disease and life, complaints, smoking history, professional and domestic hazards. Auscultatory signs of chronic bronchitis are harsh breathing, prolonged exhalation, dry wheezing, whistling, buzzing, wet wheezing of different sizes. With the development of pulmonary emphysema, a box percussion sound is determined. Confirmatory methods. Radiological. Verification of the diagnosis is facilitated by radiography of the lungs. The radiological picture in chronic bronchitis is characterized by reticular deformation and increased pulmonary pattern. In a third of patients, signs of pulmonary emphysema. Radiation diagnostics allows you to exclude pneumonia, tuberculosis, and lung cancer. With the help of bronchography, the architectonics of the bronchial tree is assessed, the presence of bronchiectasis is excluded. Laboratory. Microscopic examination of sputum reveals its increased viscosity, grayish or yellowish-green color, mucopurulent or purulent nature, a large number of neutrophilic leukocytes. Bacteriological culture of sputum allows to identify microbial pathogens, Streptococcus pneumoniae, Staphylococcus aureus, Haemophilus influenzae, Moraxella catarrhalis, Klebsiella pneumoniae, Pseudomonas spp, Enterobacteriaceae, etc. Endoscopic. The degree of activity and nature of inflammation in chronic bronchitis is clarified during diagnostic bronchoscopy. If it is difficult to collect sputum, bronchoalveolar lavage and bacteriological examination of bronchial washings are indicated. Functional. The severity of respiratory dysfunction is determined during spirometry. Spirometry in patients with chronic bronchitis demonstrates a decrease in VCL, vital capacity of the lungs, of varying degrees. An increase in MV, minute respiratory volume, in case of bronchial obstruction, a decrease in FVC, forced vital capacity of the lungs, and MVL, maximum ventilation of the lungs. Pneumotachography shows a decrease in the maximum expiratory flow rate. Laboratory tests for chronic bronchitis include general urine and blood tests, determination of total protein, protein fractions, fibrin, sialic acids, CRP, C-reactive protein, immunoglobulins and other indicators. In case of severe respiratory failure, ABS, acid-base balance, and blood gas composition are studied. Treatment of chronic bronchitis. Exacerbation of chronic bronchitis is treated in hospital, under the supervision of a pulmonologist. In this case, the basic principles of treating acute bronchitis are observed. It is important to exclude contact with toxic factors, tobacco smoke, harmful substances, etc. Pharmacotherapy of chronic bronchitis includes the administration of antimicrobial, mucolytic, bronchodilator, immunomodulatory drugs. Penicillins, macrolides, cephalosporins, fluoroquinolones, tetracyclines are used for antibacterial therapy orally, parenterally or endobronchially. In case of difficult to separate viscous sputum, mucolytic and expectorant agents, ambroxol, acetylcysteine, etc., are used. Bronchodilators, euphyllin, theophylline, salbutamol, are indicated to relieve bronchospasm in chronic bronchitis. It is necessary to take immunoregulatory agents, levamisole, methyluracil, etc. In severe chronic bronchitis, therapeutic, sanitary, bronchoscopy and bronchoalveolar lavage can be performed. To restore the drainage function of the bronchi, methods of auxiliary therapy are used: alkaline and medicinal inhalations, postural drainage, chest massage, vibration, percussion, breathing exercises, physiotherapy, UHF, ultra-high-frequency therapy, and electrophoresis on the chest, diathermy, speleotherapy. Outside of exacerbation, a stay in the sanatoriums of the southern coast of Crimea is recommended. In chronic bronchitis complicated by pulmonary cardiac insufficiency, oxygen therapy, cardiac glycosides, diuretics, anticoagulants are indicated. Prognosis and prevention. Timely comprehensive treatment of chronic bronchitis allows to increase the duration of the remission period, reduce the frequency and severity of exacerbations, but does not provide a lasting cure. The prognosis of chronic bronchitis is aggravated by the addition of bronchial obstruction, respiratory failure and pulmonary hypertension. Preventive work to prevent chronic bronchitis consists of promoting smoking cessation, eliminating unfavorable chemical and physical factors, treating concomitant pathology, increasing immunity, timely and complete treatment of acute bronchitis.